So if you've got questions, please raise your hand, and Jeremy will bring the microphone around. First question.
Yes. It's excellent meeting. I am so glad I'm here. And from New York City, I also do house call. I'm a geriatrician. And my question is, when you start a new practice with a direct pay and you are surrounded by so many clinics and the practice who take insurance, how you marketing, how you do your marketing, how you attract the patients, I'm from Flushing, Queens, and there's about over 200 internal medicine in the same neighborhood.
So I'll start. Like I said, I think marketing is one of the biggest challenges. What I did is I just started telling people about what I was planning to do even before I started it. When I was at, the local LHA League meeting, or I was at my kids' play group. I mean, the very first family that joined me, that signed up with my practice, their son went to a play school with my son, and we happened to be chatting about it. And she's like, "Wait, you mean you'll come to my house?" And I said, "Yeah." And then as I wanted to try and build more, I actually had families that were patients of mine host a, get to know about modern mobile medicine practice. So they invited their neighbors and folks that they thought might be interested in this model to come. And I just basically told them, this is what I do, this is how it works. I think a lot of people love the idea. I think what holds a lot of people back is the addiction to insurance. People are like, "But I need my insurance." And I say, yes, you need insurance just like you need car insurance for that catastrophic, unexpected cost. But you're gonna have a kid that's gonna, come down with the flu. You're gonna have a kid that's gonna fall off the monkey bars and, sprain an ankle. You yourself might suffer from migraines, or your husband might have high blood pressure, and so what those expected costs are. And when you can help them understand, and I would do this is what this costs. In terms of labs, I would put up this is how much, if you had XYZ condition and these are the labs that I need to order, this is what it would cost. And they're blown away because, again, what people pay cash prices for is far less than what they're getting with insurance. And they just don't understand that because they've been so immersed or drowning in the insurance model that they can't get their head above water to see clearly. So that's how I would do it. I would do, just groups, and then it's word of mouth. My newest patient actually lives outside of my area. She came to my practice because one of my patients does home physical therapy, and she loves it. And she was telling one of her patients about me, and then the next thing I know, she said, "Would you see this patient? She would love." So a lot of it has been word of mouth. My partner has partnered with a couple of other practices, there's an OB practice, so they see all the women for the women's health, but dads and kids need care, so he actually rents space out of their office a half a day a week, and that's been a great way to draw in more patients for his practice. So.
Could you pass the microphone?
Yep.
Over this way? So I want to answer some of that too, and I didn't get to this in my talk, but one of the industries that rivals the health insurance industry as far as flakiness is marketing. So you can spend a lot of money on people who won't do much for you. They will promise you the moon as far as marketing goes. And believe me, I have sunk tens of thousands of dollars into this, radio shows, et cetera. So you have to be careful in how you market yourself, but I think Dr. George said it best, that the number one thing you have going for yourself is patient satisfaction, is patient's word of mouth, and be careful to get those Google reviews. Ask every patient to review you on Google and Yelp. You'll rarely get a negative review. I get negative reviews. They all involve people that it's all about money. But basically, I have very positive reviews, and we put those on our website, and we just use those to market and to promote. And so that you can self-market yourself and save a lot of money.
Okay.
I just want to take a slightly different approach to it. There can be 1,000 doctors, but it's not you. So what makes you unique, what makes your practice special, nobody can copy. That's how I do it. I mean, I'm sitting on 15 ENTs within a block of each other. And I don't care. They don't do what I do. They don't see the patients the way I do. They don't have the same approach to healthcare. And it's not about the competition. It's about getting, like, I feel like I'm the best kept secret. That's how I took it, right? So your job is to get that secret out there, let people know who you are, what you do, and you will get patients.
Okay. This question is for Dr. Red and, in a way, for Dr. George also. My name is Dr. Robinson, and I'm in the Atlanta area. I have a rather unique situation. I've trained and have done ER work as well as urgent care, but primarily I do almost exactly what Dr. Red does now. We have been going at it for about 3 to 4 years, but primarily, initially I started out in a dermatologist's office. And about 6 months ago, we segued into doing it on our own. And we learned a lot of things when we were with the dermatologist's office, but that was under insurance. Since we've gone to the cash base, it has been a more interesting experience when you're running your own shop, but we've learned a lot. The question is this here. In those instances where you may have to refer a patient to a specialist for more intensive care. I'll give an example. We had a young kid whose pathology came back as a melanoma off of his earlobe. And it almost took an act of Congress to get this kid in to see a specialist. We essentially had to go ultimately through the Emory system, and Dr. George knows more about that since she's from this area. But my question to both of you is, how do we navigate the specialist referral system, particularly in my case where I'm dealing with a lot of skin lesions that may be more extensive than I can handle. I think Dr. Red can probably do more of it than I can since he's specifically trained in general surgery. But also to Dr. George, what do you as a specialist look at in terms of dealing with a physician who is cash-based? What's in it for that specialist, and how do you approach them? So it's a two-pronged question. And the second part of this is marketing. I attend a lot of health fairs. I go out and speak on skin lesions and what have you. But what happens is, once they hear my background of urgent care and emergency medicine, they want to throw every question there is that covers a whole gamut of diseases. So I'll wait on the answer.
We have a consortium of independent, physicians' offices, primary care, GYN, psychiatry, ortho, I'm ENT. So we basically have joined together. We started talking. We knew that we had the same mindset, and we started referring within our group. And it's gotten larger, and you really can keep it within that cash-based mindset. We all know the price. We are able to tell the patient what the cost is up front. I have a website so people can actually even prepay for their services, including surgery. So it's all about finding like-minded doctors, and there's so many more now than there ever were. And I'm a specialist, so most people think specialists don't do it. So it's actually a really nice niche because most of my colleagues don't do it. And they don't even offer cash prices, which I totally don't understand. But, it's when you have one patient who understands it and they start telling their friends and telling their family, it really is, it just fulfills itself, frankly.
Yeah, that's one of the biggest problems I face as well. I really see a lot of people with hand injuries. I had a restaurant owner come in and say, I'm going to send you all my cooks and people who get cut because it's way cheaper than the emergency room, and I'd rather send them here because they'll get out of here faster. But sometimes those go beyond what I can do. Last week I saw a guy cut his finger pretty badly and clearly got his extensor tendon, and he needed a hand surgeon. I do have some folks that I can call, and I feel like I can say, look, this guy needs to see you, and they'll see him. But that's kind of built up over the last 30 years of being a surgeon in the community where I am. I would love to have a consortium like that of people that are like-minded that would do the same thing. That's what I'm looking for.
I want to thank everybody because I always learn so much at these at these meetings. I had one comment, one question, and one plug. So the comment is, not all hospitals are evil. I've found, as I've gone through this process, and I'm an orthopedic surgeon, I've actually found hospitals that are enthused about doing this in a cash basis, and they've worked with me to do that. So shop for hospitals that may be encouraged by what you're doing. There are other people that like that. And a surgery center, same thing here in the Atlanta area, that they like what we do. From a cash pay practice, the patient pays me and we pay them. So it works out for their benefit as well. And then the plug, I guess, if somebody does know an orthopedic surgeon in this area that is interested in pursuing this, I'm looking for somebody to join me in that process here in the Atlanta area. But then the final comment, or the question is, I've made about every mistake there is that you were talking about, Dr. Powell, and so I appreciate it, and I can relate to it. So my question for you is, what is the EMR that you've settled with? I've been through about 6 in my lifetime. So.
Atlas MD.
Okay, that's what I figured. Thank you very much. So.
Thank you. Very encouraging presentations from all of the panelists. One theme that comes through so powerfully to me was summarized in a brief statement, like so many others, from Ronald Reagan, where he said, freedom works. Freedom and choice is what I see all of you have in common. But my question is, what would it take to have a revision in either the state or federal level? Any willing provider law would break down these barriers of the foolish networks that the insurance companies want to set up. Why can't patients be reimbursed afterward from their insurance company for care that they've sought out and have been pleased with? The assumption of the politicians and the insurance executives all seem to be that the patients are incapable of choosing the right health care for them. And all of you have proven that to be false.
Well, I'll take that first. That's the big myth of healthcare, and it's pushed down the throats by politicians, the press, pundits every day. That you can't have health care without health insurance. As I write in my book, I would like to thank the health insurance industry for showing us how to change an entire healthcare system, and that's basically the high deductibles. Again, everything we've just talked about in the last 10 minutes revolves around the fact that the system is changing, and people are starting to wake up to that fact. Including physicians. Again, I don't mean to plug my book again and again, but I did write a piece in there about a local neurologist that refused. I called his office and said, hey, listen, I have a patient, I want to send him over to you for cash. And the receptionist, or the person who answered the phone was like, I'm sorry, let me get you the office manager. I've never heard that question before. And so the office manager came on and she was like, we don't accept cash. And I said, well, gosh, that puts you at odds with every other business in the U.S. Maybe you should consider it, because high deductibles are changing. And I had a very reasoned and measured conversation with her. Well, about 2 or 3 weeks later, the neurologist came to my office with lunch and said that, hey, listen, you got a great point. And for all these office-based visits and things that just aren't that expensive. Now, I'm not talking about the surgical referrals and stuff like that, which obviously that's why we need health insurance. I like to point that out. That's why we need health insurance in many cases for catastrophic stuff. But for the routine, mundane stuff, it's my position that no office visit should be covered by health insurance. And patients realize that with their high deductibles. It's time for physicians, including specialists, to start realizing that as well. And they have to if they want to stay in business.
And that's very true, that there are a lot of participating physician practices where cash is basically foreign currency. It's foreign to their whole concept of operation.
Well, I'm sorry to hog the microphone, but I have a hashtag on Twitter. I call it Don't Stop Repealing. And it's basically we need to repeal a bunch of laws. The law that nobody seems to understand or even talk about these days that started all this and really got the ball rolling was the Hmo Act of 1972. After that, things changed. That gave the health insurance industry the power to do things that no other industry in the United States can do. No one else can price fix with their competitors, which, if you think about it, we are the competitors for the health insurance for the patient's money. So no other industry can do that. No other industry can restrict patient choice and restrict your trade like health insurance networks can. So it's going to take a repeal of that. Basically what this involves, and I talk about this a little bit at my first video podcast. Is it's going to take basically replacing incumbents, getting people in there who aren't bought off by the health insurance lobby. One of the Texas candidates I was supporting, who unfortunately lost in the primary, he made a public vow not to take any money from the health insurance or big pharma lobbies. And I think that we ought to start seeing candidates who do that and start publicly disavowing these things. That's the only way that's going to change. That's a big, that's going to take a huge effort, but that's really the only way it's going to change. But public education is always, it's never a waste in that regard.
And as I recall, it was Ted Kennedy who was one of the co-authors of the HMO Act, signed into law by Richard Nixon. But years later, Ted Kennedy came back proposing a bill to protect people from the abuses of the managed care industry, which he brought to the public.
See, I don't think we have to wait. It's here now. You go with direct primary care practices, you choose medical cost sharing, you buy supplemental policies. Vote with your pocketbook. If you wait for someone to do it for you, it's not going to happen. I mean, I've been in DC multiple times, and they just don't get it, and they don't care. They love to see doctors in pain. They think we're the enemy. If we make a penny, that's too much in their opinion.
That's right.
And that's one of the legislative aides that told me that. Don't tell anybody that you're having a hard time, because then they think they're on the right track. This is the mindset that we're dealing with, right? So ultimately, we have to take our own power back, take our pocketbooks back. I don't have health insurance. I don't believe in it, personally. My office staff has medical cost sharing, and I said Aflac as a supplemental. Why don't you have a policy that costs you less than $20, $30 a month, that if God forbid you get diagnosed with something crazy, you get a check written to you. Then you get to decide what you do with the money. If you want to leave the country, if you want to go to the biggest, baddest, cancer care, whatever center that you want to, nobody's going to tell you that it's not medically necessary, you don't need a pre-cert, and you probably would get you would get a cash pay price, probably 70-80% off what they're billing you with your insurance plan. You don't have to wait for anybody to do that. You can do it now. I can now afford to cover my employees with health care coverage, and it's a fraction of what I used to pay with an insurance plan. It's really easy.
I am a layman member of AAPS, and I thought the question from over there about what do you do about specialists was really on point, because when I'm thinking about medical insurance and when I'm talking to my family about it, for example, with my sister, she's like, well, I can't do cash. I have to have something for emergencies and big ticket items. And from our perspective as laymen, we don't know the system. We don't understand the compensation system. We're kind of at the mercy of the advice that we receive. So being completely ignorant about the payment systems, except how insurance works, because that's the culture, what would you recommend to people who want to go cash but don't know? For example, if we sign up with a concierge and we have some kind of cancer or we need heart surgery, then how do we even proceed from that point? I'm totally in the dark about that. I would have no idea what to do. And I don't know if the doctor would tell me what to do.
I think this is where being a member of a health sharing ministry can really make a difference, because the health sharing ministry pools funds, and they will work with you and help you advocate to get the best prices. So you're not, I think that's one of the hardest things for patients. They're afraid to be kind of on their own with a big bill or, a serious illness that might, cost them a great deal of money. But when you're part of a health sharing ministry, it's not only you have all these other people within the ministry that are pooling funds and sharing the risk essentially, but the health sharing ministry staff really works to help you find the best option, and will work with you to negotiate lower costs so it doesn't bankrupt you. Yeah, that's part of the value add, as Kevin said.
So I just wanted to share my model of medicine and then a comment. I'm a psychiatrist, and I don't know if that makes me a little bit different, but I have a cost sharing. So I'm like you, I'm a mom. I don't want to work more than 10, 20 hours a week. So I have cost sharing with my overhead. And what I do is I pay a flat 25% of what I make, not what I bill, but what I make, 25% goes to the person who owns the building, and the other people in the building are psychotherapists or other things, but I'm the only psychiatrist, the only MD in that building. And it's 25% of what I actually make, not what I bill. Number one, so that's very cost effective, and he covers the rent, he owns the building. He covers the electricity, he covers the internet, he covers all of the stuff in there. It's only 25% of my overhead. Works really, really well. I have 200 square feet, but that's all I need because I just got to talk to my person, so it works out fantastic. I don't have an answering service. I have my cell phone. And my patients can reach me 24/7, and they do, and they don't abuse it. I don't take insurance, but I will bill to insurance, so that speaks to you back there, which is that they pay me up front, and then I'll give them a bill, and they can do it. Where I'm getting in trouble is with the prior authorization. Psychiatry we are off-label on everything. So where I am finally getting caught up, and the system is actually strangling me, is getting prior authorizations for medications, particularly second-generation atypical antipsychotics, which we use off-label all the time. And I spend hours trying to get the PAs on that. I can't find a way around that, number one. Number two, I think a bigger mission, and I don't know how to help do it, this is my first meeting, but our bigger mission is actually educating both medical students and also educating people who don't know what they don't know. People come to my practice, they don't know that they're missing this. They don't know that they're missing a physician interaction. They don't know that they have they don't know this. They actually don't know that what we all grew up with in medicine is what we think is normal. They don't even know that. They think that they're supposed to wait 3 hours and see their doctor for 15 minutes. So that's what I have to say.
And with that, I think it's time to wrap things up so that people have a chance to go back to their room before the reception. And there will be people available again, to answer specific questions afterwards. Has to be very brief.
It has been mentioned that learning other skills. In Cincinnati, Ohio, April 18th through the 22nd, the International College of Integrative Medicine will be having their spring seminar. That's a little short notice. In Minneapolis, October, there will be the orthomolecular approach to cancer. If you want to get amongst the folks that take cash and you want to learn a different skill set for taking care of your patients, I would encourage you, the website is www.icimed.com. That's the International College of Integrative Medicine. And you come learn a lot of things that you never learned in medical school or residency. Thank you.
Okay, great.
I just want to make one more comment too. I think the idea of networking and not reinventing the wheel. So at Modern Mobile Medicine, if you want to join our practice, you can live in Timbuktu. I mean, as long as we can figure out the laws. I pay a percentage of my fees, a percentage of my patient fees goes towards the practice. So it just makes it so much more affordable. Like you were saying with the cost sharing idea, so you're sharing the cost. Because I think the biggest thing for doctors is the startup and the fear of how do I begin, where do I find a lawyer, how do I, create a website. We need to really work together, and I agree, we need to get into the medical schools, and that's one of the things that I'm passionate about, both with direct primary care and with fertility awareness. And whenever I speak to medical students about anything, I always talk to them about both, because we need to let them know.
Okay, for those who are not attending the dinner tonight, remember to turn in your CME forms if you want your CME certificate. For the rest of you, we look forward to seeing you. 6 p.m. is the reception. Again, it's the first quarter to the right down the hall. Salon